Hi, my name is Eric Westerman, and this is my presentation for FNP3, and it is on scabies. So, for the patient, we have Jane West. She's a 25-year-old female. She has a 3-week history of itchiness all over her skin that is worse at night. She presents to the clinic complaining of a generalized, intensely itchy rash. It's been 3 weeks. It started on her hands and wrists, and it spread to her stomach and thighs and armpits, just essentially all of the folds of her body and her trunk. It increases at night when she sleeps, which severely has disrupted her sleep schedule. She reports no recent exposures or illnesses or new medications. She has tried over the counter Benadryl but hasn't received any relief from that, and her roommate has developed a similar rash. Her post medical history is not really pertinent to what she's experiencing now. She had tonsillectomy in 2018. She takes an oral contraceptive pill daily, and she has no known drug allergies and seasonal allergies. Her social history: she's a 25-year-old girl. She lives with her one roommate and two cats in Pittsburgh, PA. She's a graduate student at a local university, and she works as a barista. She reports social alcohol use, just drinking on the weekends, but denies any tobacco or illicit drug use. And she's been in a monogamous relationship for 6 months. She takes an oral contraceptive pill, and she maintains an active lifestyle. Her family history: her mom and dad are both alive. Her dad has no pertinent medical history. Her mother has a history of hypertension. Her paternal grandparents are both alive. Grandfather has no pertinent medical history. Grandmother has a history of type 2 diabetes. And maternal grandparents, grandfather has a history of hypertension, and maternal grandmother has no pertinent medical history. And there is no family history of skin conditions or autoimmune diseases. For her review of systems: constitutional. She denies any fever, chills, or unexplained weight loss. She has no changes in her appetite, and she reports just the significant sleep disturbance from the itching. HEENT. She denies headaches. She reports her vision is good, denies eye pain or discharge. She reports her hearing is good, denies ear pain or discharge, and she has no congestion or sore throat. Skin: she has this 3-week history of this intense full body itching. It worsens at night. She endorses us small red bumps, tiny blisters, and scaly patches, but she denies new moles or changes in existing moles. Chest and respiratory: she has no cough, shortness of breath, or signs of increased work of breathing, no wheezing. Cardiac: she denies any chest pain, palpitations, or edema. Gastrointestinal: she has no nausea, vomiting, diarrhea, constipation, abdominal pain, heartburn, or reflux. Genitourinary: she denies any urinary issues, no dysuria, frequency, urgency, or discharge. Musculoskeletal: she denies joint pain or swelling. She denies muscle pain or weakness. Neuro: she denies numbness, tinginess, wiggling, weakness, or dizziness, and she denies history of seizures. Mental health: she reports increased irritability due to her sleep deprivation, but otherwise no significant anxiety, suicidal, homicidal ideation, and she reports her relationship with her boyfriend is happy. For her physical exam, her vital signs look good. Her blood pressure is 122/64, heart rate 72, respiratory rate 16, temperature 36.8 orally. She's 5'6", 58 kilos. She has a BMI of 20.7, which was within a good range for her height and weight. Constitutional: she appears uncomfortable due to the itching, but she appears her stated age, good hygiene and grooming. She's cooperative and alert. HEENT: she has normocephalic, pupils are equal round, react to light. Her external ears are normal, tympanic membranes pearly gray visible, landmarks, nasal mucosa pink and moist, oropharynx pink and moist, and she has no palpable lymphadenopathy. Her skin shows this widespread erythematous papules and vesicles, most prominent in the web spaces of her hands, wrists, anterior axillary folds, umbilicus, and lower abdomen. Some areas exhibit crusting and pustules. Several small linear grayish-brown burrows, they are 2 to 5 millimeters, are visible on the web spaces of her fingers and wrists. For chest and respiratory, her chest is symmetrical, breath sounds are clear. Cardiac: she has a regular heart rate and rhythm, no rubs, murmurs, or gallops, no edema. Gastrointestinal: abdomen soft, flat, and untender. She has positive bowel sounds. Genitourinary: no signs of infection, inflammation, or structural abnormalities. Musculoskeletal: she has full range of motion in all joints, no swelling or deformity. And neurologic: she's alert and oriented ×4. Her gait is steady and coordinated. Problem list. So the main issues with Jane is that she has a 3-week history of this generalized itchiness that is notably worse at night. She has the widespread erythematous papules and vesicles. There's evidence of linear burrows on her hands. She has the sleep disturbance due to the itchiness, and she has a contact exposure with similar symptoms, which is her roommate. So my differential diagnoses. My top differential diagnosis is scabies. This is a possible diagnosis related to the erythematous papules and vesicles that are prominent on her trunk and between the folds of her body. There's evidence of linear burrows on her hands. Scabies is usually severe and worse at night, which is consistent with Jane's presentation. It occurs through direct and prolonged skin-to-skin contact. It commonly occurs among families or sexual partners. And she has the history of the close contact with her roommate. Insect bites, that's my second on my differential diagnosis list. This is possible, specifically bed bugs, possible diagnosis related to the nocturnal itching and widespread papules. However, bug bites typically appear in a linear pattern of bites found upon awakening and the lack of the characteristic burrows and specific distribution that is seen with Jane's presentation. Next, I have irritant contact dermatitis. This is possible due to the widespread rash and intense itching. The worsening of symptoms at night might be related to a new detergent or fabric softener used on her bedding. This diagnosis is lower on my differential list because the linear burrows are not usually seen. Atopic dermatitis, eczema is my last one, and this is a possible diagnosis related to the widespread pruritic erythematous papules. However, the sudden onset, intense nocturnal itching, and distinct linear burrows make this diagnosis less likely. Sarah also has no reported history of eczema. So for my diagnostic tests and lab results, I would want to get a dermoscopy, and this is a handheld dermatoscope is used, and it helps locate the mites and burrows, and this will guide where to take skin scrapings for a definitive diagnosis. This dermoscopy will guide the next test, but it will not provide a definitive diagnosis. Next, I would do a scabies preparation, and this will confirm a diagnosis of scabies. A skin scraping will be performed. This involves gently scraping the affected area of the epidermis where mites are likely to reside. The collected material is then placed on a glass slide and examined under a microscope for the presence of scabies, mites, eggs, or fecal matter. Visualizing the skin will also help rule out eczema and bedbugs. I would also obtain a CBC, and this will just likely demonstrate elevated eosinophils if the patient has scabies, and it will also assess for inflammation. And the dermoscopy showed the dark triangular shape visualized, and this is commonly what you would see if the patient has scabies. The scabies preparation was positive for scabies mites, and the CBC is elevated, mildly elevated, at 1500. My primary diagnosis is scabies, and this is based on the linear burrows on her hands, the household member with the similar symptoms. The scabies preparation is positive, the CBC has the mildly elevated eosinophils, and my pathophysiology for scabies is the Scarpotes scabies mite burrows into the host skin. It lays eggs that trigger an allergic reaction, and this is what would lead to the elevated eosinophils. And this reaction manifests as an intense itching, particularly at night when the scabies are active, and the appearance of linear burrows on the skin. And then I have some pictures of where the scabies would burrow into the life stages between their eggs to becoming full-grown mites, and so on. So my recommended treatment plan for Jane is, for pharmacologic, I would do permethrin topical 5% cream. This is I would recommend her apply it to her entire body from her neck down to the soles of her feet one time. She should leave the cream on for 8 to 14 hours before washing it off, so it would be best to do this before bed. If the mites are still observed 14 days after the initial treatment, we could discuss reapplying the cream. Some possible side effects for permethrin, although these are rare, would be a burning sensation, pruritus, stinging of skin, erythema of the skin, abdominal pain, discomfort, nausea, vomiting, dizziness, headache, and fever, although not likely seen. I would also prescribe ivermectin, and this is an oral medication. I would prescribe 200 mics per kilo, taken as a single oral dose, followed by an additional dose 1 week later. Possible rare side effects for this are pruritus, fever, skin edema, papular rash, pustular rash, urticaria, arthralgia, and synovitis, and lymphadenitis. Non-pharmacologic treatment, I would recommend that she treat her close contacts, so letting her boyfriend and roommate know, and they should get the permethrin cream as well. I would recommend that she wash all clothing and bedding and towels that have been used within the past 72 hours in a hot water cycle and dry on a hot cycle. Items that can't be washed should be put in plastic bags and sealed for at least 72 hours. A week would be better. And I would recommend they vacuum all furniture and carpets. Follow-up. So I'd follow up with Jane in 1 to 2 weeks just to assess if the treatment was effective and manage any secondary complications. Also at this time, I would educate that The itching may persist for several weeks, even after successful treatment due to the immune response of the dead mites. So the dead mites will flake off of her skin, but she still might experience the rash and itchiness for at least 2 to 4 weeks. And I would advise her to avoid scratching to prevent any further secondary infection, like impetigo and so on. Possible retreatment would also be discussed if her burrows or active lesions are seen, new burrows or active lesions are seen in 2 to 4 weeks. Or if the itching worsens, second application of permethrin will be advised. I listed some community resources for Jane. I would recommend a dermatologist if Jane has any other skin concerns beyond the scabies or requires further treatment after the 2 doses of permethrin. I would provide a local dermatologist, which I've done here at Forefront, for her to see. The CDC, I would just give her information on this. It provides information on scabies, the spread and prevention, and how the scabies will dissipate over time with treatment. Central Outreach, scabies, I would recommend that for her, Pittsburgh Central Outreach, because scabies is spread through close contact. She says she's in a monogamous relationship with her boyfriend. I would just want to investigate where these scabies had come from. It may have come from her roommate, the close contact there, or her boyfriend possibly could be not monogamous. Regardless, I would want her to get an STI test, just because the likelihood of an STI occurring with the scabies is higher. Women's Choice Network, just providing information on women's health services for Jane. And then the Allegheny County website, it lists all health services available in the area that might be beneficial to her. And that is all. Thank you for listening to my PowerPoint and have a great rest of your day.